Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. The Mayo Clinic Proceedings recently updated their guidelines for the treatment of restless leg syndrome. The AASM is also in the process of updating its guidelines. We had a request to do an episode on the treatment of RLS with a specific request to start with the basics. Since this was a request, we didn't want to wait for the updated AASM guidelines, although we do plan to discuss those once they've been released. Instead, we reached out to Dr. Rachel Salas to help us. Along with her colleague, Dr. Sara Benjamin, we will review treatment options that align with the new Mayo Clinic recommendations. Dr. Salas is a professor of neurology at the Johns Hopkins Center for Sleep and Wellness. She has research and clinical expertise in restless leg syndrome and is often asked to provide a second or third opinion on refractory RLS. Dr. Sara Benjamin is the medical director of the Johns Hopkins Center for Sleep and Wellness. She came to academia after being part of a comprehensive community neurology practice for 8.5 years. Thank you both for joining us today.
It's so great to be here.
Thank you so much.
So let's start with the basics. Sara, why do we get restless legs?
Some people are more predisposed to restless leg syndrome than other people, and it most likely has to do with the availability of iron in the central nervous system. It could be due to a lack of iron in the systemic body, and then therefore, by default, there is not enough iron in the central nervous system. And in other cases, there's probably a problem with transporting iron to the central nervous system.
So, Sara, you've worked in the community and in academia. Do you have a specific approach in how you ask people about restless legs?
Yes, you do have to define it, especially because people, I would say historically too, have been told that they had restless leg based on a sleep study, right? Mm-hmm. Like you see a lot of that. It's like, oh, I have restless leg. I found out on my sleep study. Mm-hmm. And so you have to dispel that that's not restless leg. So what we're talking about is a pattern of discomfort in the legs that happens more later in the day when the patient's at rest, and that movement helps. So, and I'll ask the patients, well, what do you do when you have this feeling? Do you feel like you want to get up and walk, or how do you handle it? If they say that they just let it pass, usually that's not restless leg. The patients really do usually need to get up and move.
And I'll add to that. So with the criteria before, even if they meet all of those criteria and technically they have restless leg syndrome, again, when we start thinking about treatment, they have to have other consequence, like they have to have some daytime or sleep disruption for us to really consider even talking about treatment strategies, right? Because there are patients that just meet the criteria, but it's not a problem for them, right? Again, once or twice a week, or even maybe might not even meet the criteria, but they may say like, yeah, I have it a few times a week, but it's not a problem for me. I mean, I usually can get to bed.
Or people say, I just tend to ride my exercise bike before bed, and then after that it settles down. That's fine, right? You can adapt.
We had kind of talked about how the guidelines have changed recently. Rachel, can you outline the changes for us?
Yeah, the biggest change is the ordering of the medication of choice that we use that's first line. So for a long time, dopamine agonists have been the number one treatment option for patients with RLS. But now the recommendation is you start with the alpha-2 delta calcium channel ligands. And the reasons for that are really kind of multifactorial. One of them is really the side effect profile is really the highlight. So less of a chance of augmentation, or really not really any augmentation with these type of medications. They have a better side effect profile. So some of the compulsive, obsessive behaviors that we might see in patients with low dose dopamine agonists are not there. And so overall, it just has a better side effect profile.
So do you see that a lot of that impulsivity with the dopamine agonists?
It's very interesting. I would say that we do. It's there. A lot of times we don't ask about it. So I'll give you an example. Like I've had many of our patients that come to our center are have augmentation. So they've been on dopamine agonists many times at higher doses. And so the treatment strategy often obviously involves weaning them off the dopamine agonists and switching them onto maybe the alpha-2 delta calcium channel ligands. And when they come off and I'm seeing them in follow-up, a lot of times I'll ask them, is anything change in your behaviors? And they'll ask like, well, what do you mean? And I'll say, did you have a hobby that maybe you're not picking up anymore? And most of the time when you ask, it's there. It's subtle, right?
Huh.
It's not like our patients that have Parkinson's are a lot higher doses, but I would say most of the time there's stuff there.
Huh. So a hobby. I've never asked about a hobby.
Yeah, it kind of presents itself like as a hobby, like it's just something that they pick up, and the family and even the patient kind of say, "Oh, it's just something I like doing now." It becomes a hobby, and then you wean them off the dopamine agonist, and you can kind of have them reflect back, and they'll say, like, I've had patients that do like woodworking, right, and they were really interested, even selling things on the internet or in markets.
Huh.
Had other people like go see Broadway shows in New York, that compulsion to see a show in New York, even though the same shows might be like closer to home or in their hometown. And then once you get them off, that compulsion is not there. So again, not anything dramatic where it's
Huh.
causing negative consequences, but yeah.
Huh.
I've had two patients that I can think of that had very dramatic um, problems with
Okay.
impulsivity that really like made them almost bankrupt, almost destroyed their life.
Oh my gosh, what do they do?
Compulsive gambling,
Yeah.
really to the point, compulsive collecting, like comic books, to the spending lots and lots of money getting these rare comic books. And one patient also was going to prostitutes,
Oh my
and
gosh.
then that behavior stopped when he came off the medication.
Wow. Okay, I need to change how I ask that question, I suppose. Okay, so,
Yeah, I
so
would say that's probably, I don't know, Sarah, were these patients were like kind of high doses? Like if I think the lower doses, like it's probably because that sounds like more of the Parkinson type patients. So I wonder if
Yeah.
they were on like either longer or higher doses than we
mm,
typically use for
I
RLS.
just think these were extreme situations. I don't
Yeah.
think that,
okay,
it's going to
so
happen.
what do we start with now? Like, is there a certain order that we should do this in? For like restless leg syndrome, like what's the first line medication now?
So the first line medication, and I agree with this new practice parameters that are, we had a group of well-known experts in RLS, and using the alpha 2 delta calcium channel ligands is really the number one treatment strategy now.
And so which one do you start with?
Well, that's a good question. You have things like you got to think about who the patient is, right? So again, most of our patients with RLS, especially the more complex, maybe older, they may have other medical disorders, other symptoms, specifically neurological symptoms. So like you got to be careful with the alpha 2 delta calcium channel ligands because dizziness,
Mm,
sleepiness, maybe even some confusion. So and then weight gain, right? So water retention is another thing. So I kind of see like what's on the table for that particular patient, and if weight is an issue, I might maybe start first with pregabalin, right?
mm,
And then, I think what's important is counseling the patient that this isn't a medication that you take like as soon as you take it, your RLS is like completely, you know, improved, right? It
mm.
takes time to kind of get up to the dose that you need to. So I would say that most of the time we're working over a few weeks to really get the patient to an adequate dose. Um, so pregabalin, obviously that one's FDA approved for the use of restless leg syndrome. Gabapentin and the longer acting gabapentin are definitely viable choices. You just got to be careful on the side effect profile for all three of these, particularly that dizziness. And often I use these medications and dose them at night, which that helps tremendously, I think, not only to treat their symptoms of RLS, but to minimize the side effect profile.
So when you start, let's say gabapentin, do you start really low, like 100, or do you just go right to the like 600?
So I tend to always, my rule of thumb is really to try to start as low as I can. With that being said, unless the patient says like I have, I'm very sensitive to medications, or I tried this medication in the past and had dizziness, then those type of patients, or they're on a lot of other medications that I am worried, I may start them as low as 100. But typically, I start people on 300 and kind of course it over a week or two, and then kind of move on up. I mean, most of my patients for RLS, if we're talking about gabapentin, usually are on doses, 1,800. We used to have higher doses, 27, even at one time 3,600. And obviously, we got to be very careful with renal function and other potential side effects. But I would say for the most part, most patients with RLS that are on gabapentin are probably around 1,800, 2,700, and maybe even as low as 1,200 for the most part.
Okay, wow, that's way higher. That's way higher than I thought.
Mm-hmm.
Huh.
Yeah. I mean, I'll most likely give patients, if I'm going to start on gabapentin, start off with a 600 milligram tab, tell them cut it in half for the first few nights. But if it's tolerated and not effective, just go to that 600 pretty quickly.
Okay. What about the people who are on hemodialysis, right? Because we know that restless leg syndrome is associated with morbidity and mortality in that population.
Often we have to dose the alpha-2 delta medication to be given differently on the days of dialysis. It'll be dialyzed off, and they may need additional medication to sit in the chair and have dialysis. So it's something to be very aware of and kind of customize your treatment for their dialysis schedule and dose it appropriately.
So how do you dose it appropriately after dialysis?
Yeah, so it does need to be given again after dialysis. And so there'll be a dose for the non-dialysis days and the day of dialysis, a dose to be given after dialysis. And I think if you look up gabapentin, it actually tells you a little bit about how, like the renal dosing. I think that sometimes it's laid out. To look at that.
Yeah, that's helpful. So what about the pregabalin? How do you dose that?
So the pregabalin, for me, I kind of do the same thing, right? So like if they have a lot of other medical concerns, there is maybe a concern of weight gain because maybe we can't try other medications. So I may start as low as 75 milligrams and quickly titrate up if I can. Most of the typical patients that don't really have a lot of medical issues or I'm not that concerned, I definitely will start at 150, have them do that for about a week or two, kind of have them send me a message on the electronic medical record, let me know about any side effects or anything like that. And after that, I increase them to 300 nightly. And most of the patients with RLS are about 300, 350 for the most part on average at night.
Do you see a lot of water retention with that?
For me, with pregabalin, it's not as common as, like, for instance, gabapentin, but you do see it. So you got to tell the patient about it. But I don't see it as often as compared to gabapentin, for example.
Is that your experience too, Sarah?
It hasn't been a big issue. There's always some patients, and I feel like it's not always dose dependent. I mean, I remember starting someone with gabapentin, and one patient that for some reason her arm swelled instead of her legs, but just one of those things. Sometimes it just happens.
Because I think sometimes when you're talking about side effects, right, like it's like the pregabalin has that heart failure sort of concern. And so that one is the one that patients really, because they Google and we talk about it. And that's the one that makes them a little bit more concerned about taking that medication. Is that something you guys see too?
Yeah, I mean, I think it's always a concern. We talk to your patients, especially if they have the risks for that. And at the end of the day, there's a little bit of bias, I think, for our center because typically we definitely tend to see the more complex presentations of RLS with augmentation. Often our patients have tried many of the medications. So for us, it's a serious conversation of retrying medications that the patients sometimes are not necessarily interested, right? Because they tried it in the past and it didn't quote unquote work. But once we get to an agreement on what medication of choice we're going to talk, we do talk to them about the side effect profile. We put it in their electronic medical record so they could see the full report. But honestly, I haven't had major issues or haven't seen that as a major side effect because I think we try to select the medication up front and have those conversations first.
So I heard you say something about retrying a medication. Do you re-challenge with like a dopamine agonist?
Well, yeah. I mean, I think at this point, I really try to tell the patient that it's really the art of medicine when they're that complex in terms of their RLS, right? So a lot of times patients may say, well, I already tried gabapentin in the past, it didn't work. And, if you just stop there, then you're going to miss some key elements. And one of those key elements is many times they didn't get enough get up to a higher dose. Like they were just on 100, or
Oh, sure.
they were taking it as needed kind of thing.
Right. And so there's so many combinations of these medications. And so a lot of people, they say, well, I failed this, I've failed that. But okay, if you failed gabapentin while you were already highly augmented on a dopamine agonist, it doesn't mean that once you're off the dopamine agonist that the gabapentin won't help you.
Oh, that's a really good point. So you mean it was sort of they were on two medication, or was that part of a cross taper?
I've seen many patients who've seen other doctors first,
Sure.
right? And so they just kept adding on rather than cutting back.
Oh, I see. Okay, yep.
And so once someone's highly augmented, adding more other medicines, they aren't going to work. Like augmentation becomes its own thing. So you don't really have the restless leg. What you have is the augmentation. So you have to kind of take that away sometimes and then see where they are with the restless leg and what works for the restless leg.
So how do you, because I'm imagining that your practice is probably, obviously different, right? Because you're the second or third opinion. And so does that change how you approach it then? Because you're sort of, you have this heightened awareness of, oh, I think this is probably augmentation.
Probably in those cases, it's a variety. I mean, we're like Hopkins in your backyard here too, so we have both the local patients, everyone, who have very straightforward things and the more complicated patients.
Oh, I see. Okay.
So it's a mix, really.
So how do you ask about augmentation?
It's all in the history, right? So
Right.
like how long have they been on their dopamine agonist? Where are the symptoms? A lot of times with augmentation, the symptoms have progressed to other body parts. And believe me, we've seen it in many other body parts, in more advanced cases. What time are the symptoms starting? A lot of times you'll find that the symptoms are way earlier, like even in the morning hours. Intensity is obviously increased as well. But you got to tease it apart because sometimes people present and they look like they have augmentation, but in reality, they're taking some kind of other medication that may be exacerbating, or perhaps their iron hasn't been rechecked in a while, and that's an issue. So it's all, it always goes back to the history and really getting that clear picture. But for augmentation, as everyone knows, it's really progression of the symptoms to other body parts earlier in the day, more intense. And, you often find the history of that the patient recently increased or had been increasing the medication, either by the clinician telling them to, or sometimes the patient doing it on their own.
Mm-hmm. You know what my favorite thing is when I find Benadryl.
Yeah.
That's
right.
that's my favorite thing to find, to be like, oh, hey, did your symptoms get worse when you started taking this, over the counter thing?
Yeah, especially right now, right? People are getting colds and, people are like, oh, it's over the counter. It's not a big deal.
Right.
So antihistamines, they're hidden in everything, right? And that's a big exacerbator for RLS.
Let's take a short break. And when we come back, we'll talk more about the updated Mayo Clinic Proceedings treatment guidelines for restless leg syndrome. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Join colleagues and subject matter experts February 23rd through 24th for Sleep Medicine Trends 2024. Explore emerging technologies and innovations in sleep medicine that will enhance patient quality of care. Learn more at aasm.org/events.
Welcome back to Talking Sleep. We're talking with Dr. Rachel Salas and Dr. Sara Benjamin about RLS and the updated treatment guidelines. So when you see a patient, do you start, like the ones where Hopkins is in your backyard, do you start with labs or do you start with a trial of medications? What's your approach?
I'll start. I guess my first approach is to really figure out, is this a patient who has augmentation? Do they just have RLS, is just not taking the medications in the best way? Like, how can I tweak it? And for me, timing is everything. So I'll look at that. But if it's a patient that has never been diagnosed, which I'll say is pretty rare in our clinic, then I obviously make the diagnosis. I do labs, including iron. I might do some other laboratory studies, but most of the time that kind of preliminary work has been done by the primary care. But definitely iron. And even if that was done, a lot of times I'll repeat it because it's been some, over a few months. And then I'll start them usually on, whether it's gabapentin or pregabalin or, extended release. It just depends on what, again, the profile is of the patient. And then I'll have them come back in a couple months and then we kind of go from there. But I often tell the patients to check in with me via my chart, and I can make adjustments on medication dosing, and give, kind of guidance until, in the meantime, before I see them again and follow up.
Yeah, I try to figure out, ask them, is this something that happens every night, or how many nights a week? How many nights a month? Is this a problem? And so not everyone needs to be on medication for restless leg. If it's a more occasional thing and we can find non-medical treatments, if it's only happening, once in a while, they don't always have, sometimes people kind of report it's a phenomenon, but it's not something that they actually are seeking medical treatment for. They just want to know more about it, right? And know how to manage it. And some people will say, well, if I know it's an iron problem, I would want to go on iron, but I don't necessarily want to go on a prescription medication.
Yeah, that's funny that you say that, because in my neck of the woods, a lot of people are really adverse to being on medications. So if we can sort of look at, well, is this an iron issue? I hear what you're saying. We see that too. So I heard you say iron. Do you do just ferritin, or do you do like the whole TIBC and iron saturation? And
yeah, we definitely do the panel as well as the ferritin, because, as you know, ferritin can be an acute phase reactant and can be falsely elevated. I also really counsel patients that they shouldn't be doing this blood work should be done fasting, off of supplements for 2 days before you do the blood work. And because it's an acute phase reactant, if you're feeling sick, if you have a little sore throat or cold, hold off. Do this, when you're feeling well.
That's a good point. So do you have a ferritin target?
I mean, my target is usually 75 nanograms per milliliter. The thing about that target is, yeah, there's probably some people who have a problem with transport of iron and really do need a higher, because we're measuring the peripheral blood, right? We're not really measuring what's going on in the central nervous system. So there are some people that probably need higher than that for it to get to the central nervous system, but then they would need IV iron. But so as far as replacing iron orally, if I feel like I don't try to have a target higher than the 75 with oral iron.
And how do you navigate the IV iron?
I trained under Chris Early and Richard Allen, who, in that center, we would actually order our own iron infusions on the patients, kind of like go through that. When we transitioned over to our center, the Johns Hopkins Center for Sleep and Wellness, we made a center decision to send those patients out. So we really work with our colleagues, the hematologists that are very comfortable with RLS, and there are some out there that are, and even for newer hematologists that may not be that comfortable, many times it's just having a conversation with them, and we usually share protocols that we can use. I mean, there's all these caveats that come into play when it comes to iron. So our center just made the decision that it's just best done to the professionals, right? The hematologist. So we refer, and then, we get patients from all over the country. So a lot of times, even if we were doing the IV iron infusions through our center, which we're not, it really entails us connecting with the clinicians in their hometown, where they, obviously are going to get more convenient care with the IV iron infusions.
So what I've always found kind of weird is that if you order the iron, like the ferritin for restless leg syndrome, is not covered, and you have to have a different diagnosis.
Yeah. I use disorder of iron metabolism as my diagnosis, because it really is a disorder of iron metabolism.
Oh, that's a good idea. Okay. So what other labs do you draw?
I'll say that, it depends, right? It is like if the patient's brand new, doesn't have a primary care, definitely I'll consider, some other things looking for potentially neuropathy, right? I use a thyroid, maybe a panel, looking for if there's diabetes, things like the hemoglobin A1C. But it's very rare. Like I said, patients that are really coming to our clinic usually have seen not only their primary care, who's done some initial baseline blood work, but many times the patients we're seeing have seen even other sleep specialists, and they're coming for, second, third, fourth opinions.
So I feel like our practices are diametrically opposed. Because, so I will usually see them de novo, right? And then, I kind of have my list of labs to collect. And so, you talked about thyroid and hemoglobin A1C, ferritin and iron studies. Do you do B12 folate, LFTs too?
Yeah, I may do that, especially if the patient also has daytime fatigue, right? If they're like kind of, I do think it's worth, like if you're looking for that.
So, Sara, I heard you say earlier that, sometimes people with intermittent RLS, it's not particularly bothersome, that you would do a non-pharmacological intervention. So what is that? Is that stretching? Is that moving? Or is it one of these gadgets?
Well, usually I talk to people about, what seems to make their restless leg feel better or feel worse, and then kind of come up with an individualized plan. One thing that I found with patients with restless leg is there's usually a sweet spot with exercise, like a moderate amount of physical activity that is helpful. And if it's a day they overdo it or a day that they aren't able to get their moderate activity, it'll be worse. So we kind of sometimes talk about building that in. We've used a lot of overlap with some of the sports massaging kind of things that have been helpful for patients. Like there's the foam roller. So if you can't really, always walk around, there's things you can do like the massage gun, things that are just easy to use in your bedroom. And then just another thing sometimes we talk about is just like some physical movements before going to bed, to kind of like we have a handout that's about yoga poses for sleep. And that can be really helpful for people too. So instead of just pacing and thinking about restless leg, they have kind of a mindful routine of movement, which can help their legs settle down and their mind settle down. And another point I want to make about restless leg is that the same level of inactivity, depending on what the brain is doing, can have different levels of symptoms. So it's very interesting how you can have a person who can say, I could play cards seated at 8 o'clock at night with no problem, but I can't sit and read a book at 8 o'clock at night, right? So they're sitting the same way. So there's something different about what the brain is doing. And sometimes you can use that and help them like find things to do to change that connection a little bit, to help them quiet their legs through keeping their mind busy in a different way.
So like distraction.
Mm-hmm. For some people, if it's not very, very severe, a lot of people are able to use those type of strategies.
So I love the idea of a foam roller and the massage gun. I had never considered the massage gun before. That's a great thing to sort of help patients take care of it themselves.
Yeah, and so I definitely make that recommendation as well. One of the newer things that I've kind of had some, I always tell patients, it's like Goldilocks, right? You got to find out what works for you. And people try all sorts of things. Some of the newer things that are out there, obviously, is getting formal massages. There's cryotherapy now, whole body cryotherapy. There's like compression therapy that you can go to like a wellness center and get like 30 minutes or an hour of compression therapy on your legs or your arms. So there's a lot of things out there, and I want to encourage people to try different things, but be mindful about safe things, right? Sometimes patients read things on the internet and they may not only not be helpful, but actually could be potentially harmful.
So compression therapy, are those like the squeezy boots?
Yeah, they're like these large, like zip-on kind of boots that inflate, and you can dial up. And most of the wellness centers will have those available, and you can do like 30 minutes up to an hour, and you can pick how intense you want it. And I've tried. I don't have restless leg syndrome, but I like to try like things that are out there, and it's pretty non-invasive. And if anything, I mean, you're like getting a focal kind of massage, right? So things to try.
And cryotherapy, that's cool.
Yeah, there's no studies on that, so I want to point that out. Like, I'm not necessarily saying cryotherapy is in our practice parameters, but there may be some opportunity there. Like definitely some maybe could help in improvement with kind of recovery, especially for athletes and things like that. But I think as long as you don't have major contraindications to trying some of these things and they're kind of low yield, it might be worth trying.
What about the foot brace? Have you tried that?
What, the foot brace?
That Restific?
Oh, no, I mean, I haven't tried it. I mean, patients have asked me about it. I haven't had any patients that came back with some, whether they got it or not and whether it was beneficial. I don't know. Sarah, do you have any experience?
No, I don't.
I've certainly gotten asked about it for sure.
You have. That's interesting. We had a like 2 or 3 samples, and I had one person that was like, no, this doesn't do anything. And I had one that was just like, this is amazing. Like it was just the best thing ever. What about the that Relaxis pad that used to be around? Did you ever use that?
I had some patients that had used it, and again, it's always a mixed bag, right? That's why I always go back to find the Goldilocks, like just try different things out, which are going to work for you. Just be mindful of what's going to be safe or not. And so definitely talk to your doctor about it.
Mm-hmm. And there's a new one, right? That band around your leg?
Yeah, that one I don't know too much about yet. And I know there's a lot of stimulators out there as well. So yeah, the good news is there's a lot of research happening, and hopefully in the upcoming years there's going to be like more kind of FDA approved options. But there's a lot of devices out there that may be worth, again, like Dr. Benjamin was saying, kind of distracting the patient, kind of implementing things into your bedtime routine, particularly if you're trying to minimize the amount of medications you're using.
So when do we start to consider narcotics?
Ooh, that's the question, right? Yeah. So, I mean, a couple of reminders when it comes to opioids, right? So it's not first line. It is in our practice parameters, but you have to try the other kind of gold standard treatment options first, which obviously include the alpha-2 delta calcium channel ligands, the dopamine agonists. And then for the occasional patient, you don't have these often, but every now and then you'll have that occasional patient that says, I just get RLS like 3 times a week. If I just had something to get me to then that might be a good choice. But benzodiazepines honestly are not traditionally used like often. But if they have augmentation and we're trying to bring them off, and maybe they can't use alpha-2 delta calcium channel ligands, or they've already used them, we've maximized them or not, then opioids can be a great option. But it's not easy. Not only are we in a global pandemic when it comes to the opioids, but there's a stigma, right? And often our patients, have concerns, and their families have concerns. So it's not an easy decision. It's not first line, but when done right at low doses and really connecting with your patient and explaining to them, I always say, Chris Early always said this. He said that RLS is a different beast compared to chronic pain, and that still really resonates with me. We just don't see the substance misuse that patients with chronic pain may have when it comes to the opioids. And in fact, there's a paper that came out recently looking at the long-term safety and the stability and efficacy of opioids with RLS. Now, the study's not perfect, but it does highlight that, they're pretty safe when done right and at low doses.
So which ones are you talking about? Codeine, morphine, methadone? Well,
I mean, I think people are going to get tired of me saying this, a little bit of the Goldilocks, but, honestly, from my anecdotal, like my experience, I tried, oxycodone, hydrocodone, maybe like kind of my initial, because you can't really go straight to some of the other ones. But honestly, I have the best impact when we get to it is low dose methadone. It works really well. The side effect, again, low doses. Often, maybe with the alpha-2 delta ligand medications as well, but certainly if you can get the patient over to just one, even if it's the opioid. And I have several patients on low dose doing extremely well on a low dose of methadone.
Sarah, is that your experience too?
Yeah. So most of my patients who are on methadone maybe had started on oxycodone. And we look at the morphine equivalent dose, and when the oxycodone dose starts getting up to the morphine equivalent of like 5 milligrams of methadone, then to transition them that way. And then I'd also add, just as far as deciding who's going to go on opioids, I like to have some assessment of their breathing at night too before doing that. And if they do have sleep apnea, make sure it's adequately treated.
Yeah, that's a really good point.
Yeah, absolutely. And thanks Sarah, for bringing that up. I mean, that is a must, right? And that's often, something that we struggle with because a patient will come to our center specifically to discuss treatment options for their RLS, but they've not been adequately evaluated for something like even, obstructive sleep apnea, which 80% of people out there have and aren't adequately, or they're not diagnosed and therefore not treated. And to add an opioid or any hypnotic or pain pill, anything like that, onto a patient with, undiagnosed, untreated apnea, that's a big issue. So that is a conversation that I always have with my patients, especially if opioids are even in the discussion up front because they have augmented or they're more complex.
So you're kind of referring to the 80% that we estimate is undiagnosed, right?
Correct.
Yeah.
That's exactly right. That includes the patients with RLS, right?
I mean,
They're not immune.
Right. No, many of these tertiary referral restless leg patients turned out to have severe sleep apnea. And then sometimes I have some patients at their local sleep doctor who manage their sleep apnea, but I still want to kind of peek in on it, right? Make sure that it's, even though they have the local DME answer, I want to make sure that apnea is met when I'm making my recommendations for their restless leg treatment.
Well, I was just going to make the note because I think this is important in discussing with your patient who has RLS, is saying that we got to make sure that if you have apnea, that it's adequately treated. And here's why. Because if it's not, and you have apnea, you could wake up in the middle of the night or early in the night, whatever, you can wake up and guess what will happen? Your RLS kicks in. So sleep apnea untreated can be an exacerbator of RLS and perpetuate it.
Yeah, absolutely. So if you have somebody on like a dopamine agonist and you're like, okay, this is augmentation and you want to start an alpha-2 delta calcium channel ligand, how do you do you cross taper? Do you how do you figure that out?
Well, I think it depends. I think every probably sleep specialist may have a different kind of approach. For me, I'll look at which dopamine agonists they're on. If they're on the longer acting, I may move the timing. I find that a lot of patients that are on the dopamine agonist are taking it at the wrong time. So if your RLS kicks in and then you take your dopamine agonist, that's a problem, right? So I may start first by just moving things around, having the conversation about you have risk factors for apnea, let's get this and going in the meantime, and kind of moving the medications while I'm waiting to reassess or assess for apnea, looking at their iron levels, looking at other things that I want to look at. And so when they come to follow up, we discuss the sleep study, decide whether or not apnea is on the table, whether we need to treat it. And by that time, they're going to be able to give me some feedback on just the movement of time, but they already know the goal is to get them off the dopamine agonist. If they're not on the alpha-2 delta ligand medication, I'd probably start implementing at that next visit there, and again start working up, and then again just reiterating that the goal is going to be able to get them off the dopamine agonist. And so I try to be pretty frank and give them worst case scenario, because we've all seen withdrawal from the dopamine agonist, and I think that's important to talk to your patients about.
So do you split the dose too? Do you do one? Yep. Okay.
Yeah, I often do that. It's like move it closer, like maybe take it at 5 p.m. I have to ask when their symptoms are starting. I'll definitely divide it. And then, when I start weaning them off, I'll probably drop the earlier dose, go to the evening dose, maybe even slow it down in every other night. It just depends on the patient. It's all about precision medicine and personalization. There's no right or wrong in my book from my experience, and it's just really meeting the patient where they are and what their concerns are, and how bad their withdrawal symptoms are. But I try to have a step-by-step play so that they feel that we're always doing something.
Yeah, and I'll say, I think if possible to cross titrate, it might be a more gentle approach, but I have patients who've tried to cross titrate and they're not successful. And in those patients, they really do sometimes need to just lower the dopamine agonist, have a washout period, and then all of a sudden the alpha-2 delta, the other medicine works now. That never worked when they were still on it. And so there's some like that, but you really do have to give them a clear picture of what this withdrawal period is, which can be very, very severe in many patients. And it have to be at the right place and time to do that. Yeah. Which may be taking off work, not driving. I mean, this is, I have patients, adults who work, who it's so bad that I'm like in conversation with their, I'm talking about like, a working 40-year-old, and I'm like have to talk to their parents because, they really get themselves in such a bad place with this, that it just becomes like, they can't even manage. And then you also have to realize that coming off of the dopamine agonist, sometimes people have really bad, if they're prone especially to depression and things, it can come out a lot and it can be in a very bad place. And so not everyone is really a candidate to totally come off. And in some of those patients, they do better switching over to like the rotigotine patch, like having which has a little bit less augmentation. I have both, people who are just prone to depression, people who are very old, who I think that I'm afraid that they're going to have a cardiovascular event coming off of it.
Yeah.
I had a patient come to me once who was in her 90s, who was in a nursing home, and she had a little basket on her walker, right? And she pretty much going around all day taking carbidopa, levodopa.
Oh my gosh.
Throughout her day. And, it was, she came with her daughter and we talked about all this. And, even she came in the office, her systolic blood pressure was already like 180, right? And I'm like,
oh my
whoa.
gosh.
I'm like, if I try taking her off of this, what's going to happen? I'm afraid she'd have a stroke if I took this away from her.
Oh no.
So you have to customize the plan. But I have had patients, I can think of at least one patient who was 80 years old, who had been on dopamine agonists for years, and she couldn't cross titrate, and she had to do the washout, and she did it. And she was just very proud of herself, right, for getting through. It was rough, but she got through it. But it's a lot of hand-holding. You have to be in a position where the patient can touch base with you every few days and tell you how they're doing it, if they're doing this washout, because it can be very, very severe.
That's such a good point about depression. In where I am in Fargo, we have, of course, long winters and it's dark, and we tend not to wean antidepressants in the winter. Like if we're talking about MSLT or something like that, we're like, we don't really want to do it in the winter. And everybody's like, yes, I don't want to do it in the winter. Like it's just such an accepted fact where we are. So I have to ask you guys, what about the bar of soap in bed? Like, how does that work?
I have no idea how that works. It's been around forever. I don't know if it just is something there, so the patient maybe like moves their legs a little bit, something kind of comfort, something to, I don't know.
Sara, any wisdom?
Yeah, I don't know the science behind it, but if it helps somebody, great.
Yeah, it was something, I just find it so curious, right? I trained in Kentucky and then in Georgia and then, North Dakota, Minnesota, like all of this stuff. And it's always there. Somebody always does it. And I have no idea how it works. And I'm like, well, it's probably not going to hurt anything. Like, have at it. So any final thoughts?
There's more awareness about restless leg syndrome by our colleagues that maybe not necessarily our sleep specialists. So I think there's a lot more awareness. I think people are really in tune about like ruling out like mimics. There's a lot of things that look like RLS but aren't. So it's all in the history. Again, restless leg syndrome is a clinical diagnosis. Patients have to meet all of those diagnostic criteria to be diagnosed. And like Dr. Benjamin mentioned earlier, is like if a patient tells you, I just have this RLS symptoms, they meet the criteria, and it's just symptoms twice a week, then we're not going to advocate to treat those patients, right? Because like the symptoms aren't, and most of them will tell you, I'm not really interested in medication, even though those 2 times a week is a problem. And then having conversation, just connecting with your patients, retrying medications in the past, thinking about the ideal timing for medications. Again, I do all my alpha-2, the delta ligand medications all at night versus like 2 or 3 times a day or in the morning. Nighttime's better, especially, with the side effect of sleepiness and dizziness. So it just really comes down to connecting with your patient and really kind of seeing what their goals are, what time what time are they taking their medication, what time are their symptoms happening. And, there can be a lot of precision that can be done even just by getting that information first before even getting into like starting them on a different medication or weaning them off or whatnot.
I love that approach. Sara, final thoughts?
So it's important to take a very careful history for your patients to see what symptoms they have to make sure it really is restless leg and not a mimicker, and really see how the restless leg is impacting their life and see what medications they've tried and failed and what combinations, and then what you can do to customize care for each patient.
You said you have to dispel patients against this. So how do you explain that they have PLMD and not, or PLMs and not restless leg syndrome?
I explained to patients that restless leg syndrome is actually a clinical diagnosis. It's based on how they feel and what they're reporting to me. It's not something you see on a sleep study. If somebody is moving their legs in their sleep, those are called periodic limb movements in sleep. And that's very common, especially as people get older or if they're on antidepressant medications. We see that a lot, and that's not necessarily something that you need to track down or treat.
Yeah, and I would add to that, when we see periodic limb movements on a sleep study, like if you order a sleep study and it comes back and you're seeing those, and you look at their medication list, like Dr. Benjamin mentioned, they're not a, antidepressant or another medication that could be, exacerbating that, then you definitely would, I would say that would be a cue to question your patient about symptoms of RLS, right?
Yeah, that's a really good point.
Right. It's definitely worth having that discussion with all your sleep patients. Just, you can just make some kind of blanket statement like, does any discomfort in your legs make it hard to sleep? And make sure you open up that conversation.
Sorry, I was going to mention one thing, just because I do see this a lot. Like you'll have a patient that comes and says, oh yeah, I have that restless leg syndrome. So my question always to that is, oh really? Oh, well, who diagnosed you with that? And they often will say, oh, I haven't, it's just what I have, right? So you want to clear that up. And it's not just with restless legs. Sometimes patients may just kind of self-diagnose. So you want to just kind of be inquisitive a little bit about that. Like, oh, when were you diagnosed? Who diagnosed you? Your primary care? Or did you see a specialist? RLS seems to be one of those that I don't know, for whatever reason, patients may say, oh, yeah, I have restless leg syndrome. So you don't want to put that in the chart unless they really do have that diagnosis.
Yeah, because they may mean that they're jumping their legs during the day or yeah.
Correct. Yeah. It could be just that they have a habit, right? They're restless and they're just tapping their foot.
Yeah, that's a really good point that we really want to clarify that we're, talking about the same thing.
Right.
Well, thank you both for joining us today and to help us better understand the new guidelines regarding treatment for restless leg syndrome.
Well, thanks so much for having us.
Thank you so much.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.